An implanted port is a central venous access device that is surgically placed beneath the patient's skin. It is used to deliver long-term IV therapies and can be used to obtain blood samples as well. You may have also heard these devices referred to as portacaths or subcutaneous ports. To access, maintain, and deaccess an implanted port, you must take certain precautions and follow a specific procedure to ensure the patient's safety and the continued operation of this device. This video will highlight these important aspects of caring for a patient with an implanted port in use. At St. Mary Mercy Hospital, all RNs are allowed to access and deaccess ports if they are comfortable and competent in the procedure. If it is the first time a nurse is performing this task, have a second RN present that is competent in the procedure to oversee and verify proper technique. This can be a nurse from the unit, or you can call the vascular access team at either extension 5672 or 2784. Once you have demonstrated the ability to successfully complete the procedure, you are safe to access or deaccess ports on your own. To understand the processes involved in using an implanted port, it helps to understand the device itself. It is surgically placed below the patient's skin. Usually, it will be found on the chest, but it is also possible for the port to be placed in the arm or the leg. It will likely be at least slightly visible under the skin, but depending on the patient's anatomy, you may have to palpate to find it. What you are feeling or looking for is this device. The actual port is covered in a membrane that is not present on this demonstration piece. It covers a small reservoir that is attached to a catheter. The catheter is tunneled under the skin until it reaches the internal jugular vein. Here, it enters the vein and is fed down towards the heart and stops in the superior vena cava. This is the same place that central lines and PICC lines terminate as well, which is why this is considered a central venous access device. The implanted port allows for quick and effective delivery of IV treatments. It limits the number of peripheral IV and lab pokes because blood can be drawn from these devices. Once you have identified that your patient has an implanted port, you will want to access it. You first need to gather the supplies. You will need sterile gloves. Have at least 2 pair accessible. In the event that you break sterility, you can quickly change to a new pair of sterile gloves and continue your procedure. Clean gloves. A microclave, sometimes referred to as a needleless adapter. A biopatch. Chlorhexidine swabs. A number of swabs may be available in the pod rooms. For this procedure, take either one of the large 10 milliliter winged applicators or multiple ChloraPrep single swab packs. A sterile saline flush. These come in various packages, but ensure that this is a sterile flush, not the standard saline flush supplied on the units. If you do not have one available, you can call distribution or the ICU and have one sent to you. An empty 5 or 10 cc sterile syringe. These are the syringes that are supplied in the pod rooms. An occlusive dressing. You can use any Tegaderm dressing that is large enough to completely cover the access site and device. In this video, we will demonstrate using the Tegaderm IV Advanced dressing, which should be available in your pod rooms. Surgical masks for everyone in the room. Swab caps for every open microclave and Y port. And finally, the needle or access device to access the port. The needles come in various lengths. The standard length is 3/4 inch, but also come in longer 1 inch and 1.5 inch lengths. Longer needles are only needed when the port is further away from the surface, so if the patient has significant adipose tissue or breast tissue, or if the port is implanted in the patient's leg or arm, you may find that you need a longer needle in order to reach the port. There are 2 types of access devices available, the Gripper Plus and the Gripper Plus Power Pack. Choosing the correct device is important. Some implanted ports are power injectable, which means that fluid can be pushed very quickly into a port with intense pressure, and the port will not be damaged in any way. This is important for some procedures such as CT with contrast, because the contrast dye must be injected in this manner. A power injectable port can handle this pressure easily. However, other ports are not designed for this level of stress and would be damaged or destroyed by the process. There are a few ways to identify which type of port the patient has. First, the patient may know and be able to tell you. Second, the patient should have a card in their wallet at all times that says what type of device has been implanted. But sometimes the patients don't know or are not reliable, and sometimes they don't have their cards with them. So the third and most reliable method is to look at a chest x-ray that shows the port. If it is a power injectable port, on the x-ray you will be able to see the letters CT somewhere in the actual device. If you do not see those letters, it is not a power injectable port. Which brings us back to the question, which access device should I use to access this port? If you have verified that it is a power injectable port, use the Gripper Plus Power Pack. This device has power injectable tubing that will hold up to increased pressure. The tubing of the power pack is always blue, so you can tell which access device was used simply by looking at the tubing. If you have verified that it is not a power injectable implanted port, use the standard Gripper Plus. If you are unsure of what type of port it is, use the standard Gripper Plus. The tubing attached to this needle is clear. It is not power injectable. To ensure that no one attempts to power flush a non-power injectable device, we will always default to the clear tubed Gripper Plus if we have not verified definitively that the port is indeed power injectable. Both needles are designed the same. The needle is oriented perpendicular to the hub. These are used to access the port by pressing them straight down onto the port. The goal is to get the tip of the needle past the port's membrane and resting inside of the reservoir. Around the needle, on the base of the hub, is a foam pad. This serves only to prevent pressure injury on the patient's skin. It does not have any disinfectant quality, so you will be applying a biopatch under the device for the purpose of disinfecting. On the back of the device are small tabs to be used as handles to stabilize the device during insertion. Once in place, the tabs should be removed by squeezing them together. They will release from the hub like opening a chip clip. With your supplies gathered, you are ready to access the port. First, make sure everyone in the room is wearing a surgical mask. Next, don your clean gloves. Palpate for the port. There are different companies that make ports slightly differently. Some feel like flat, round discs. For these, when it comes time to use the needle, aim for the center of the disc. Others may have 3 raised dots that form the shape of a triangle. For these, aim for the center of the triangle. Once we have located the port, disinfect the area. You can use one of the large applicators, or, if that is not available, use 2 of the single swab sticks together. Disinfect on and around the port. Scrub in a hashtag pattern for 1 to 2 minutes. Be sure to disinfect a larger area than your dressing will cover. You need to ensure that everything under the dressing has been thoroughly disinfected. Now the area needs to fully dry before continuing with the insertion, so while you allow time for that, set up the rest of your supplies. There is an important piece of information that needs to be addressed at this point. Sometimes a numbing spray is used to numb the skin prior to needle insertion. This spray is not sterile, which means that if it is going to be used, you have to apply it before you disinfect, not after. And you still must disinfect for 1 to 2 minutes and allow time to dry, which means the effect of the spray will likely have started to wear off before you insert the needle. But under no circumstances can this spray be applied after disinfection. Applying spray after disinfecting the site has and will lead to CLABSI and potential death. Going back to our procedure, you'll need to set up your supplies. You can use the bedside table or set up your sterile field on the patient if they are cooperative. You will need to open the dressing, biopatch, microclave, sterile flush, sterile syringe, and the needle onto the sterile field. Also have swab caps readily available, but not on your sterile field. Doff the clean gloves and don the sterile gloves. Attach the microclave to the end of the needle's tubing. Next, attach the sterile flush and prime the tubing. Clamp your line. Then detach the flush, but keep it on your sterile field. You'll need to use it later. Now, attach your empty sterile syringe to the tubing. Remove the plastic sheath from the needle. You will need to apply a biopatch between the needle hub and the patient's skin. You can put it around the needle at this point, or apply it after you insert the needle, but it must be in place before this procedure is finished. For this demonstration, we have it in place prior to insertion, as this tends to be easier. When applying a biopatch, the blue label should be facing the sky. The foam pad should make contact with the patient's skin. When holding the needle, orient it so that the tubing runs up the body toward the neck. This will allow consistent and easy access to the tubing and allow easier tubing management because it can be fed through the top of the gown. Palpate the port. Once you have it located, anchor it between your thumb and forefinger of one hand. Push the needle straight down into the center of the port in one smooth motion. Once it is in place, aspirate at least 5 cc's of blood into your syringe. By doing this, you are removing the heparin that is injected into this catheter the last time it was deaccessed. You always waste at least 5 cc's of blood every time you access a port. On that note, you should always get blood return after accessing an implanted port. If you don't, do not use it until it has been evaluated by the vascular access team or an appropriate physician. If you do get blood return, after wasting the 5 cc's, attach the sterile flush and flush the port using the push-pause method. As you are flushing, right before the flush is complete, close the pinch clamp. Then close the second pinch clamp and detach the flush. Orient the tubing so that it points up towards the neck. Remove the tabs from the needle hub by pinching them together and lifting up. Apply the occlusive dressing. A full demonstration of use of the IV Advanced Tegaderm is shown in the linked Sterile Dressing Change video. The insertion site should be visible in the window. Apply the shirt portion of the dressing loosely over the site. Ensure that it is fully occlusive, but don't stretch it over the site as you apply it. This will cause too much pressure on the patient's skin and can lead to pressure injury. Lay it gently over the site and press around the edges to ensure that it adheres to the skin. Then apply the pants portion and the belt. Be sure to initial and date the dressing. Before you finish, apply orange swab caps to all the microclaves and Y ports. When you put the patient's gown back on, feed the tubing out through the snaps at the top. This allows easy access to the line without having to undress the patient every time you need to administer a medication or draw blood. This dressing and the needle must be replaced at a minimum every 7 days. This means that every 7 days this port will need to be deaccessed and reaccessed with a new needle if it is to continue to be used. Utilize the same sterile technique every time the port is accessed. If at any point the dressing becomes soiled or starts to peel up, the dressing can be removed and reapplied without replacing the needle as long as it is intact and within the 7-day period. If you are replacing the dressing, remove the Tegaderm and disinfect the area thoroughly for 1 to 2 minutes before applying a new dressing. Follow the sterile dressing change procedure shown in the sterile dressing change video. Also be sure to chart every port access, deaccess, and dressing change in Epic using the LDA avatar. When the needle is removed, it is often referred to as deaccessing the port. You will need some supplies: a sterile Tegaderm, a sterilely packaged 4x4, chlorhexidine swabs, a saline flush, a heparin flush if ordered by the physician, and gloves. Deaccessing is usually not a sterile technique. In this video, sterile gloves are worn during the procedure, but clean gloves would be appropriate as well. When you deaccess a port, you remove the needle. But it is important to remember you are not removing the catheter. That will remain in place, and we want to ensure that it remains patent and intact. So before removing the needle, you need to first aspirate to ensure blood return, and then flush with a sterile saline using the push-pause method. If you are simply replacing the needle at this point because it has been in for 7 days, then clamp the line as you finish the sterile saline flush. If you are deaccessing the port and it will not be reaccessed at this time, after finishing the saline, you may need to flush with a heparin flush. But this is no longer protocol. A heparin flush is only used with a physician order. If it is contraindicated, or the physician chooses not to utilize the heparin, it is acceptable to simply saline lock the port prior to deaccessing. But regardless of which method is used, clamp your line as you finish the flush. With a chlorhexidine swab, begin to remove the occlusive dressing. Using chlorhexidine to remove the dressing will help to neutralize the adhesive, making it easier to remove, less painful for the patient, and less likely that you will accidentally dislodge the needle while you are pulling the dressing up. Also, importantly, if you are scrubbing beneath the dressing with the swab, you are actively cleaning the site as you remove that dressing. If you do not remove with this method, you will need to clean the site with chlorhexidine after removing the device. When the Tegaderm has been removed from the skin, there are 2 options for removing the needle. If you can easily remove the Tegaderm from the needle's hub, you can use the safe removal feature of the Gripper Plus. Secure the base of the hub by holding it against the patient, and lift up on the top portion of the hub by placing your pointer finger on the tab at the front of the hub. As you lift that piece away from the patient, the needle will be pulled out of the port and out of the patient's chest. When you feel the device click, the needle is fully removed and locked in that position. There is no danger of accidental needle sticks because it is completely confined inside of the hub. If you cannot easily remove the dressing from the access device, you can remove it without using this feature. First, be sure to stabilize the port beneath the patient's skin. It is only held in place by the skin, so when you pull that needle out, it is important that you are holding the port down and in place so that it is not dislodged by the force of the needle being pulled up. With pressure being applied to the port, pull the needle straight up and out of the patient's chest. Be careful when using this method because the needle is still out, and there is a risk for accidental needle sticks. Take a folded sterile 4x4 and press it onto the port. There may be some slight oozing of blood from the site. Hold pressure and apply a standard Tegaderm to act as the occlusive dressing and to maintain that 4x4 in its place. The port is now safely deaccessed.